Welcome, curious minds, to another deep dive. Today, we're taking a closer look at a topic that touches nearly every family you know, yet often remains surrounded by whispers and misunderstanding: mental health disorders. We've gathered some fantastic insights. We're looking at the types, the symptoms, and, well, the profound impact these conditions can have. Our mission today: to cut through some of the noise, help you really grasp the difference between, say, everyday emotional bumps and actual clinical conditions, and maybe uncover some surprising facts about how common these are and their impact on all of us. Okay, let's unpack this. We want to get you well informed quickly and thoroughly. So to start, it's really important to understand that mental health isn't it's not like a simple on or off switch. It exists on a spectrum, a kind of continuum, ranging from really flourishing well-being all the way to, well, severe mental illness.
Exactly. And what's fascinating, I think, is how subtle that line can sometimes be and how easy it is maybe to misunderstand where everyday experiences like, feeling sad after a really tough day cross over into a clinical condition. The real insight isn't just that it's not binary, but how these sort of subtle accumulating shifts can unexpectedly tip someone from thriving maybe into clinical distress, which really highlights the power of early recognition. Mental illness involves significant, lasting changes
Yeah.
in emotion, thinking, or behavior, and these lead to genuine distress and, importantly, serious problems functioning in daily life, socially, work, family activities. It's definitely not something someone can just snap out of.
Okay, so how do we draw that line then
hmm
between like a passing struggle and something that genuinely needs clinical attention?
That's a great question. Generally, mental health disorders are defined by, let's say, three key components of dysfunction or impairment. First, there's dysfunction. So a breakdown in typical psychological, biological, or developmental processes. Think of it like your brain isn't quite processing things the way it normally would. Maybe an inability to feel pleasure,
Uh-oh.
anhedonia, or an intense fear that actually stops someone from leaving their home. Then there's distress. And we're not having mild discomfort here. This is significant psychological or even physical pain. It goes way beyond what's typical. And finally, deviance. Behavior that significantly violates social or cultural norms, consistently pushing outside what's expected in that context.
Right. So what this means for us practically is we're looking for patterns, like a certain level of severity, how long it lasts, how pervasive it is, and its overall impact on just day-to-day functioning.
And professionals, they use very specific criteria, right? From the DSM-5.
That's right. The DSM-5, it's like the guidebook for diagnosis. It includes very specific time frames, criteria lists.
Yeah. And we can see this distinction pretty clearly if we compare, say, grief to major depression. Both involve intense sadness, maybe withdrawal, but grief, it often comes in waves, interspersed with positive memories, maybe. And self-esteem usually stays intact. With major depression, however, that profound sadness, that loss of pleasure, it's constant, most of the day, nearly every day, for at least 2 weeks, usually longer. And those feelings of worthlessness, self-loathing, they're really common.
That's a huge difference.
It is. Or think about anxiety. Mild anxiety, totally normal, can even be helpful, right? Sharpens your focus. But when it escalates, moderate, severe, and especially panic levels, it just completely narrows your perception. It hampers your thinking, can totally impair functioning. You might even feel like you're losing touch with reality. It's a complete shift in how your mind is operating.
Okay, that makes sense. So with that foundational understanding of the continuum, let's maybe peel back the layers a bit. Let's look at what these conditions actually look like in people. Maybe start with one we hear a lot about: depressive disorders.
Sure. So at its core, depressive disorders often mean this deep, persistent sadness, or maybe even more powerfully, a profound inability to feel joy in anything. Clinicians call that anhedonia.
Anhedonia.
And this has to be present most of the day, nearly every day, for at least 2 weeks. And it has to cause significant problems in your daily life. Under this umbrella, you have major depressive disorder, which is probably the most known, but also persistent depressive disorder, often called dysthymia. That's a more chronic kind of lower grade depression lasting at least 2 years. Then there are others like premenstrual dysphoric disorder, PMDD, and even those with a clear seasonal pattern.
Which people might know as seasonal affective disorder, or ISA.
Exactly.
So from that sort of pervasive cloud of depression, we often see maybe the other side of the coin, these dramatic shifts in mood and energy, which brings us to bipolar disorders.
That's right. Bipolar disorders are really defined by these dramatic, sometimes very rapid roller coaster-like shifts in mood, energy, thinking ability. They can swing from these abnormally elevated moods, we call those manic episodes, down to periods of deep low moods, the depressive episodes we just talked about. And in severe manic episodes, people can even experience hallucinations or delusions, a break from reality.
Okay, so what does a manic episode really involve?
Yeah.
Beyond just feeling, up or energetic.
Yeah, it's much more than just feeling happy or having a lot of energy. A manic episode is defined as a persistently elevated, expansive, or even irritable mood, plus an abnormally increased level of energy or activity. And this lasts at least a week, and it causes marked impairment in functioning, or might even require hospitalization. Imagine needing almost no sleep for days on end, yet still feeling wired. Your thoughts racing so fast you can barely keep up, talking nonstop, maybe jumping from one topic to another. Yeah. And engaging in activities with really high potential for painful consequences, like huge shopping sprees you can't afford, reckless business decisions, sexual indiscretions. Your judgment is seriously impaired. This isn't just enthusiasm, it's a profound shift, likely driven by changes in brain chemistry.
And are there different sort of levels or types of bipolar disorder?
Yes, there are. Bipolar I disorder is defined by having at least one full manic episode. People with bipolar I often have depressive episodes too, but the mania is key for diagnosis. Bipolar II disorder involves recurrent major depressive episodes alternating with what we call hypomanic episodes.
Hypomanic.
Yeah, hypomania is less intense than full mania. It's a noticeable change in mood and functioning, but not severe enough to cause major impairment or require hospitalization, but still distinctly different from their usual self. No full manic episodes in bipolar II. And then there's cyclothymia, or cyclothymic disorder. This involves numerous periods of hypomanic symptoms and periods of depressive symptoms for at least 2 years. But the symptoms don't quite meet the full criteria for a hypomanic or major depressive episode. It's more of a chronic, fluctuating mood disturbance.
Okay, that clarifies the distinctions. Shifting our focus now, let's talk about anxiety disorders. These feel incredibly common. But it's more than just temporary worry or fear, right? The anxiety is persistent, it's intense, often gets worse over time, and really interferes with daily life. Apprehension is universal, sure, but in these disorders it becomes truly debilitating.
Absolutely. And it can be helpful to think about the different levels of anxiety. There's a model by Peplau. It starts with mild anxiety, which is part of everyday living, might even sharpen your focus. Then you move to moderate anxiety. Here, your perceptual field starts to narrow. It's harder to think clearly. You might notice physical stress responses, racing heart, maybe sweating.
Okay.
Severe anxiety takes it further. Your perceptual field is greatly reduced. Critical thinking becomes pretty much impossible. You're focused on relieving the anxiety. And finally, there's panic, the most extreme level. You might feel like you're completely losing touch with reality, unable to process information. It's overwhelming and often leads to profound exhaustion afterward.
Wow. And the types here include things like generalized anxiety disorder, GAD, social anxiety disorder, panic disorder, and also phobia-related disorders, where the intense fear is tied to a specific object or situation. Each has its own unique flavor of intense worry. Now, while anxiety can feel like this sort of pervasive internal storm, sometimes it manifests in very specific, almost ritualistic ways, which brings us to obsessive-compulsive disorder, or OCD.
Right. With OCD, the core experience involves uncontrollable, recurring thoughts, those are the obsessions, and or behaviors, those are the compulsions. An individual feels absolutely compelled to repeat these actions, often as a way to try and temporarily relieve the intense anxiety caused by the obsessions.
Can you give an example?
Sure. So an obsession might be a terrifying, intrusive fear of contamination or germs. And the compulsion could be washing hands excessively, maybe for hours, or following rigid cleaning rituals. Logically, the person might even know it's excessive, but not performing the compulsion causes unbearable distress and anxiety. It feels necessary.
That sounds exhausting.
It really is. Other examples could be obsessions about harm coming to loved ones, leading to constant checking compulsions, or needing things to be perfectly ordered or symmetrical.
Okay. Moving on to another condition often linked to intense experiences. Post-traumatic stress disorder, PTSD. This is diagnosed after someone's exposed to a traumatic event, right? And the key is these chronic stress symptoms last over a month and really interfere with life, relationships, school, work. It's like the body's natural fight-or-flight response gets stuck on high alert.
Exactly. The symptoms tend to fall into distinct categories, which helps in understanding it. First, there's re-experiencing the trauma. This can happen through intrusive memories, vivid flashbacks where it feels like it's happening again, or nightmares. Then there's avoidance. People actively steer clear of anything, thoughts, feelings, places, people that reminds them of the traumatic event. Third is hyperarousal or reactivity. This might look like being easily startled, feeling constantly tense or on edge, having difficulty sleeping, or having angry outbursts. And finally, significant changes in cognition and mood. This can include persistent negative thoughts about oneself or the world, distorted feelings like guilt or blame, a loss of interest in activities they once enjoyed, or feeling detached from others.
It sounds incredibly disruptive.
Profoundly so.
Then we have conditions that involve a more fundamental break with reality. Let's talk about psychosis and schizophrenia.
Right. Psychosis isn't a specific diagnosis itself, but rather a symptom or a set of symptoms. It essentially describes conditions where there's a profound loss of contact with reality. Thoughts and perceptions are significantly disturbed.
And what does that loss of contact look like?
Well, key symptoms often include delusions. These are fixed, false beliefs that aren't shared by others in the person's culture, and they hold on to them despite evidence to the contrary, like believing they're being spied on or that they have special powers. And hallucinations. These are false sensory perceptions. Hearing voices others don't hear is common, but they can involve any sense seeing things, smelling things, feeling things that aren't there.
So psychosis is the symptom state. How does schizophrenia fit in?
Schizophrenia is a specific, serious mental illness. It's characterized by a continuous period of disturbance, including symptoms like delusions, hallucinations, disorganized thinking for at least 6 months, and it significantly affects how a person thinks, feels, and behaves. It impacts functioning across major life areas. A really unique and often challenging symptom in schizophrenia is something called anosognosia.
Anosognosia.
Yeah, it's essentially a lack of insight into one's own illness. The person genuinely doesn't recognize their symptoms, the delusions, the hallucinations, as being symptoms of an illness. Imagine genuinely believing everyone hears the voices you do, or that your delusions are absolute reality. This makes it incredibly difficult to engage them in treatment sometimes.
That must be heartbreaking for families. And the symptoms themselves in schizophrenia are often grouped, right?
They are, typically into 3 categories. Positive symptoms are things that are sort of added to a person's experience, things that shouldn't be there, like the hallucinations and delusions we mentioned, or disorganized speech where thoughts seem jumbled or disconnected. Then there are negative symptoms. These involve a loss or decrease in normal functions, things like reduced emotional expression, a flat affect, loss of motivation or initiative, diminished pleasure in life, anhedonia again, or reduced speaking.
So things are missing in a way.
Exactly. And finally, cognitive symptoms. These involve difficulties with executive functions, things like attention, concentration, working memory, learning new things. These can be very subtle, but significantly impact daily functioning.
Okay, let's shift gears slightly to personality disorders. These sound different again.
They are. Personality disorders are defined by an enduring pattern of inner experience and behavior, one that deviates markedly from the expectations of the individual's culture. This pattern is pervasive, inflexible, starts in adolescence or early adulthood, is stable over time, and leads to distress or impairment.
So it's more than just having personality quirks.
Much more. These patterns significantly impair functioning in at least 2 of these areas. Cognition, how someone perceives and interprets themselves, others, events. Affectivity, the range, intensity, appropriateness of emotional response. Interpersonal functioning, and impulse control.
And they're grouped into clusters.
Yes, based on descriptive similarities. Cluster A is the odd or eccentric cluster. It includes paranoid personality disorder, pervasive distrust and suspiciousness, schizoid, detachment from social relationships, restricted emotions, and schizotypal, social interpersonal deficits, cognitive distortions, eccentric behavior. Cluster B is the dramatic, emotional, or erratic cluster. This includes antisocial personality disorder, disregard for and violation of the rights of others, borderline personality disorder, instability in relationships, self-image, emotions, marked impulsivity, sometimes self-harm, histrionic, excessive emotionality and attention-seeking, and narcissistic, grandiosity, need for admiration, lack of empathy. And cluster C is the anxious or fearful cluster. This includes avoidant personality disorder, social inhibition, feelings of inadequacy, hypersensitivity to negative evaluation, dependent, a pervasive need to be taken care of leading to submissive behavior and fears of separation, and obsessive-compulsive personality disorder, preoccupation with orderliness, perfectionism, and control distinct from OCD.
That's a really helpful breakdown. Now, moving on to eating disorders. These are serious medical illnesses, right?
Absolutely critical to emphasize that. Serious medical illnesses. They involve a distorted view of weight and body image, leading to an unhealthy, often dangerous relationship with food. And it's vital to remember they can affect anyone, any gender, age, ethnicity, socioeconomic background.
What are the main types we should know about?
Well, the ones you often hear about include anorexia nervosa. This is characterized by severe restriction of energy intake, leading to significantly low body weight. There's an intense fear of gaining weight, even when underweight, and a disturbed body image. Then there's bulimia nervosa. This involves recurrent episodes of binge eating, eating a large amount of food in a discrete period, feeling out of control, followed by recurrent inappropriate compensatory behaviors to prevent weight gain, like self-induced vomiting, misuse of laxatives, fasting, or excessive exercise.
And binge eating disorder.
Right. Binge eating disorder also involves recurrent episodes of binge eating associated with significant distress. But critically, it does not involve the recurrent use of those inappropriate compensatory behaviors seen in bulimia. What's often surprising, or maybe underestimated, is just how physically dangerous these disorders can be. They can affect every major organ system.
A crucial point. Finally, let's touch on substance use disorders, or SUDs.
Yes. These are illnesses caused by the repeated misuse of substances, alcohol, illicit drugs, even prescribed medications that powerfully activate the brain's reward system. This repeated activation can eventually lead to the neglect of normal life activities, as seeking and using the substance becomes paramount. Diagnosis is based on a cluster of cognitive, behavioral, and psychological symptoms indicating the individual continues using the substance despite significant substance-related problems.
And the term addiction relates to this.
Yes. Severe SUDs are commonly called addictions. Addiction is understood now as a chronic, relapsing brain disease. But importantly, it's also characterized by the potential for recovery and remission.
What are some of the criteria clinicians look for?
The DSM-5 lists several. For example, taking the substance in larger amounts or over a longer period than was intended. A persistent desire or unsuccessful efforts to cut down or control use. Spending a great deal of time obtaining, using, or recovering from the substance's effects. Also, craving or a strong desire or urge to use. Recurrent use resulting in a failure to fulfill major role obligations, work, school, home. Continued use despite having persistent social or interpersonal problems caused or exacerbated by the effects of the substance.
It sounds like it takes over.
It really can. Other criteria include giving up important activities, using in hazardous situations, continued use despite knowing it's causing physical or psychological problems, developing tolerance, needing more for the same effect, or having withdrawal symptoms when stopping. The critical insight here, I think, is understanding the neurobiology. Repeated substance use literally rewires the brain's reward pathways. It makes the brain crave the substance intensely, often above natural rewards like food or social connection. Normal pleasures can start to feel dull by comparison. This neuroadaptation is key to understanding why it's a disease, not just a matter of willpower.
Okay, so understanding what these conditions are is one thing, hugely important. But now let's try to tackle that big question, why? Why do they occur? We know it's not a single cause and definitely not a moral failing or weakness. It seems to be this complex, often surprising interplay of factors.
Exactly. Research makes it incredibly clear. No one is at fault for developing a mental health condition. Instead, it's almost always this combination of environmental factors, biological factors, and genetic factors, often interacting and amplifying each other in complex ways.
Let's start with those environmental factors. What are some of the maybe surprising connections we see there? Things people might not immediately think of.
Well, there are the broad social determinants of health, things like systemic racism, discrimination, poverty, exposure to community violence. These create chronic stress and disadvantage that can significantly contribute to mental distress. Then, a huge factor, often overlooked in its impact, are adverse childhood experiences, or ACEs.
Your C's, right? Oh,
Yeah. We're talking about experiences like physical, emotional, or sexual abuse, neglect, or household dysfunction like parental substance abuse, mental illness, incarceration, or domestic violence. A staggering number, something like 61% of adults, report experiencing at least one ACE. And the insight here is profound. The chronic stress from ACEs can actually change brain development. It can alter the stress response systems. And there's a very strong link between ACEs and the development of mental illness and substance misuse later in adulthood.
Wow, so early experiences can literally reshape the brain's architecture and response systems.
Precisely. And then, of course, there's the impact of individual traumatic events, whether they're human-made, like war, assault, or abuse, or natural disasters. These experiences can have lasting adverse effects, potentially leading to PTSD, but also anxiety disorders, mood disorders, or even psychotic disorders in some cases. The environment plays a massive role.
Okay, that's powerful. What about the biological factors? What's happening inside the body and brain?
Well, for a long time, the focus has been on neurotransmitters, brain chemicals like dopamine, serotonin, norepinephrine. Scientists believe imbalances in these chemical messengers can lead to significant changes in behavior, mood, and thought patterns, contributing to various disorders. But what's also fascinating is how many other things can influence these chemical fluctuations.
Like what?
Things like physical illness, significant hormonal changes, think pregnancy or menopause, adverse reactions to medications, ongoing substance misuse, poor diet, lack of sleep, and of course, chronic stress itself. It's also crucial to remember the two-way street between physical and mental health. Poor mental health significantly increases the risk of chronic physical illnesses like heart disease, diabetes, cancer. And conversely, certain medical conditions, thyroid problems, nutritional deficiencies, neurological disorders, or even side effects of some medications or substances can actually cause or mimic symptoms of anxiety, depression, or psychosis.
So a doctor needs to rule out physical causes too.
Absolutely. Thorough medical workup is essential. Beyond neurotransmitters, research is also looking at other biological factors. Some studies suggest immune system dysregulation and chronic inflammation might be associated with depressive and bipolar disorders. And neuroimaging research shows differences in brain structure and functioning in people with certain mental illnesses like bipolar disorder, schizophrenia, or OCD compared to those without. So again, it drives home the point. This isn't just in your head, it's rooted in biology, in the physical workings of the brain and body.
That's a really powerful point. Now, what about genetics? It's partly genetic. Does that mean someone is sort of destined to have a condition? Or is there still a lot of room for environmental influence and maybe even agency?
That's an excellent, really important question. There definitely appears to be a hereditary pattern for some mental illnesses. For example, individuals with major depressive disorder or bipolar disorder are more likely than the general population to have close relatives with the same illness. The same is true for schizophrenia and some anxiety disorders. This strongly suggests that certain genes can increase susceptibility or vulnerability to developing a condition.
Susceptibility, okay.
Yeah.
Not destiny.
Exactly. It's not a fixed destiny. Having a genetic predisposition doesn't guarantee you'll develop the illness. Environmental factors, like those ACEs we talked about, or significant life stressors and individual lifestyle choices still play a huge role in whether those genetic vulnerabilities actually manifest as a disorder. It's more like genetics loads the gun, but environment might pull the trigger.
That's a useful analogy. So it seems for most conditions, it's a specific combination of these factors coming together.
Precisely. We see different combinations or weights for different conditions. For anxiety disorders, it often looks like a mix of genetic predisposition, possibly imbalances in brain chemistry, certain personality traits like neuroticism, and stressful life events, especially things like childhood adversity. For bipolar disorder, genetics play a significant role, but stress, disruptions in routine, and previous ACEs are also major triggers or contributing factors. OCD seems linked to differences in specific brain circuits, possibly genetic factors, and there's also evidence linking it to childhood trauma in some cases.
And PTSD.
For PTSD, the primary cause is the trauma exposure itself, but risk factors for developing it after trauma include the severity and duration of the trauma, whether there was physical injury, the level of social support afterward, and any pre-existing history of mental illness or substance abuse.
Okay, and substance use disorders.
With SEDs, genetic vulnerability is definitely a factor. Some people are just more biologically prone to addiction. But those neuroadaptations in the brain's reward system from repeated use are central. Plus, environmental factors like peer pressure, availability of substances, and especially exposure during the vulnerable period of adolescence when the brain is still developing are key. It's almost never just one single piece of the puzzle.
Right. Given all this complexity, how can we just as individuals, family members, friends, community members, how can we recognize when someone might be struggling? Being aware of common warning signs seems crucial.
It really is. And these signs can vary, but there are some common ones to look out for in adults and adolescents. Things like excessive worrying or fear that just seems out of proportion or won't let up. Extreme mood changes, not just feeling happy or sad, but uncontrollable highs or deep persistent lows. Long-lasting irritability or anger can also be a sign. Social withdrawal is a big one, avoiding friends, family, activities they used to enjoy.
Changes in habits, too.
Definitely. Significant changes in sleeping patterns, sleeping way too much or too little. Changes in eating habits, leading to weight loss or gain. Or noticeable changes in energy levels, either being constantly fatigued or unusually agitated. Sometimes more severe signs emerge, like problems perceiving reality delusions or hallucinations we discussed. Or that lack of insight, anosognosia, and inability to recognize changes in one's own personality or behavior. Misuse of substances, alcohol, or drugs can often be a sign of underlying issues or an attempt to self-medicate. And sometimes distress manifests physically. Multiple physical ailments without obvious medical causes, like chronic headaches, stomach aches, or vague pains.
And the most serious ones.
And critically, any talk or thoughts of suicide or self-harm, or just a general inability to carry out daily activities or handle everyday problems and stress. If someone's functioning is significantly impaired, that's a major red flag.
Okay. What about younger children? Do the signs look different?
They often do, yes. In younger children, warning signs are frequently behavioral or physical. You might see changes in school performance, excessive worry or anxiety, maybe refusing to go to school or clean to parents. Hyperactivity beyond typical childish energy, frequent nightmares, or persistent disobedience, aggression, or frequent intense temper tantrums.
Good to know. Now, you mentioned suicide as a critical warning sign. Can we elaborate on the specific warning signs for suicide? This feels incredibly important to highlight.
Absolutely vital. Knowing the specific warning signs of suicide can potentially save a life. It's tragically common, often linked to untreated or undertreated mental illness, especially depression, bipolar disorder, and substance use disorders. Look for someone talking about wanting to die, expressing feelings of hopelessness or having no reason to live, making plans for suicide, searching for methods online, or acquiring means like pills or a weapon, feeling like a burden to others, feeling trapped, or being in unbearable emotional or physical pain, increasing isolation, withdrawing from friends and family. Increased substance use can be a major warning sign.
Other behavioral changes.
Yes, increased anxiety or agitation. Significant changes in sleep, too much or too little. Expressing rage or talking about seeking revenge, displaying extreme mood swings. Any talk about death or suicide should be taken seriously. It's not attention-seeking, it's often a desperate cry for help. And the statistic you mentioned earlier bears repeating. Suicide is the second leading cause of death among Americans aged 15-34. It's a public health crisis.
Absolutely staggering. Which brings us to that broader picture, the sheer prevalence and the societal impact of mental health disorders. The scale is often, I think, really underestimated.
It truly is. These conditions are incredibly common, much more so than many people realize. The statistics are stark. Nearly 1 in 5, that's 19% of adults in the U.S., experience some form of mental illness in a given year. About 1 in 12 adults, or 8.5%, have a substance use disorder, and about 1 in 24, around 4%, live with a serious mental illness, or SMI conditions like schizophrenia, severe bipolar disorder, or major depression that significantly interfere with life activities.
And for specific conditions.
Anxiety disorders are the most common, affecting 19% of adults and an even higher percentage, 31%, of adolescents. Depression affects an estimated 8% of U.S. adults annually. Approximately 3% of people will experience psychosis at some point in their lives. Among young children, aged 2 to 8, about 1 in 6 has a diagnosed mental, behavioral, or developmental disorder. And as we noted, the consequences can be fatal. Drug overdose deaths in the U.S. now tragically exceed 100,000 every year. These numbers paint a picture of a widespread challenge.
They really do. So what's the profound impact of living with these conditions on individuals themselves, beyond the symptoms?
The impact on individuals is, as you said, profound and multifaceted. Functioning and quality of life are significantly affected. Mental illness causes problems in social interactions, performance at work or school, and family activities. Untreated symptoms can completely disrupt lives and put immense strain on relationships. Then there's the impact on physical health. We touched on this, but poor mental health genuinely increases the risk of developing chronic physical illnesses like heart disease, stroke, diabetes, and cancer. Individuals with severe mental health conditions and substance use disorders are actually 2 to 3 times more likely to die from preventable diseases compared to the general population. Their lifespan can be significantly shorter.
Wow.
And that psychological stress can absolutely manifest as physical symptoms, those chronic headaches, stomach aches, fatigue we mentioned. The mind and body are deeply connected.
And the risk of suicide, particularly with certain conditions.
Yes, sadly. Depression is a major risk factor for suicide. For people with bipolar disorder, the lifetime risk of suicide is estimated to be up to 20 times higher than the general population rate. It's a devastating potential outcome.
We also see mental health disorders frequently co-occurring, don't we? Like someone might have both anxiety and depression.
Very frequently. This is called comorbidity, and it's extremely common. For example, anxiety disorders often co-occur with depression or with OCD. ADHD often co-occurs with anxiety or mood disorders. And substance use disorders very frequently co-occur with other mental health conditions like depression, anxiety, bipolar disorder, or PTSD. This intertwining means that effective treatment really needs to be holistic. It has to address all co-occurring conditions as they often influence and exacerbate each other.
And what about recovery? Is it possible?
Absolutely. Recovery is possible. It's crucial to emphasize that mental illnesses are treatable health conditions. Many people with mental illness can and do recover completely or learn to manage their symptoms effectively and lead full, productive lives. However, recovery often requires a long-term, sometimes lifelong, commitment to treatment, self-management strategies, and support systems. Relapse can be a significant challenge, particularly for substance use disorders and chronic conditions like bipolar disorder or schizophrenia. Understanding relapse as part of the recovery process, not a failure, is really important.
Yeah, it's a hopeful but realistic message. Now, if we zoom out again, connect this individual impact to the bigger picture. The impact extends far beyond the individual, doesn't it, to society as a whole?
Absolutely. The societal impact is enormous in ways we might not always consider. First, there's the sheer economic burden. The misuse of alcohol, illicit drugs, and prescribed medications alone costs the U.S. economy over $400 billion every single year.
$400 billion.
Yes. That includes costs related to healthcare, the criminal justice system, accidents, and lost workplace productivity. Mental illness in general adds significantly more to that burden through healthcare costs and disability. It puts immense strain on our healthcare system. Mental health disorders are a vital concern worldwide, and the healthcare setting itself can sometimes be challenging or even re-traumatizing for survivors of trauma, highlighting the critical need for trauma-informed care approaches across all medical settings.
What about social challenges?
Untreated or poorly managed symptoms can contribute significantly to major social challenges. Things like chronic unemployment, academic failure, relationship breakdown, involvement with the legal system, and even homelessness. A large percentage of the homeless population struggles with serious mental illness or substance use disorders. But perhaps the most pervasive societal impact is stigma.
Stigma.
The negative attitudes, discrimination, and prejudice surrounding mental illness mean that nearly two-thirds of people with a diagnosable mental health condition do not seek treatment.
That's shocking. 2/3.
It is. Fear of judgment, shame, discrimination in housing or employment, it creates this massive barrier to accessing vital care and support. Overcoming stigma is one of the biggest challenges we face. Mental health conditions also have significant legal implications, touching on issues like involuntary treatment laws, competency to stand trial, and patient rights in court-related cases. Ultimately, promoting mental health, preventing mental illness where possible, and ensuring access to effective treatment and recovery support is a fundamental public health concern. It's increasingly identified as a top priority for community health initiatives across the country.
Wow. What an incredibly comprehensive and really essential deep dive. We've covered so much ground exploring that fascinating continuum of mental health, breaking down the defining features of major disorders, trying to understand that complex web of environmental, biological, genetic causes, and really looking squarely at the profound impact both on individuals and on all of us as a society.
Yeah, and I think what really stands out beyond just the sheer scale and complexity is that crucial message. These are treatable health conditions. They are not personal failings, not character flaws, which maybe raises an important question for you, the listener, to think about. Knowing these numbers now, that nearly 1 in 5 adults experiences mental illness, but that stigma keeps almost 2/3 from seeking help, how might actively challenging those misconceptions, fostering more open conversations, maybe just checking in on people in your own community, how might that begin to shift that reality, even in small ways?
That's a powerful thought to end on. Thanks so much for joining us on this truly essential deep dive. Keep asking questions, keep learning, and stay well informed.